Dear Curigliano and distinguished guests, it's my great honor to co-chair with Dr. Zhang and Dr. Curigliano. As co-chair of this meeting, please allow me to welcome all of you to attend this online meeting. I'm Dr. Binghe from National Cancer Center, Cancer Hospital, Chinese Academy of Medical Science. Before starting the meeting, I would like to say a few words. Going on for 3 months. Outbreak. Now we are gradually returning to the work, but we're still facing many issues such as traffic. We cannot gather and share our knowledge face to face with foreign guests. In this online meeting, we are very pleased to invite some doctors to give a talk and also invite some doctors as moderators and discussion guests.
There is no audio. We cannot hear him.
许教授的声音没有打开麦克。
Oh, it's okay?
Now yes. Now yes.
Now yes. Okay. I introduce everybody in this meeting. Dr. Yao Feng from People's Hospital, Wuhan University. Dr. Yang Jin from the first affiliated hospital of Xi'an Jiao Tong University. Dr. Song from Fujian Uni Medical College Hospital. Dr. Li Xingrui from Tongji Hospital of Wuhan. Dr. Zhu Li from Ruijin Hospital, affiliate to School of Medicine, Shanghai Jiao Tong University. Dr. I'm not sure. A lot of people cannot remember the name. There were also a lot of experts in this online meeting. I'm not going to introduce them one by one because of the time limit. We also have many doctors from different cities of China as audience. Today's online meeting focuses on management of breast cancer patients under coronavirus outbreak. Once again, thanks all of you for your valuable time in this online meeting. Now, please allow me to invite Dr. Curigliano. That's okay to make an opening speech, Dr.
Okay, thank you.
Curigliano, please.
Thanks a lot for your kind introduction. So I will share my screen if you agree, and I will proceed with my presentation. So here it is. Can you see my slides?
No.
No.
Just
No.
Can you see my screen?
No.
No.
Now, I believe now you see it. Can
Okay.
you see my screen?
Yeah, I can see. We can see.
Yes.
Before talking, can you say a few words for Chinese doctors and audience?
Yes, of course. So first of all, thanks a lot for inviting me to this very important seminar. As you know very well, China is helping us a lot. Many doctors from the Wuhan area came here in Regione Lombardia, and they provided us advice on how to manage the epidemics of coronavirus. I am a member of the National Health Council, and since the beginning, a Chinese doctor shared all the information with us in order to start the lockdown and the social isolation. So it's really a pleasure for me this morning to be here with you and to share our experience. That is finally an experience that we did following advice of medical doctors in the Wuhan area and the Hubei area. So thanks a lot for this. So it's really a pleasure to be here also with Dr. Binghe Xu. He is really a key opinion leader in China. He's very well known also in Europe and in the United States. And it's for me a pleasure to share with you our experience. So this morning, I will share the data on breast cancer patients in epidemics, presenting data from Italy and the management specifically in the Milan area.
Italian. Italian.
I believe first someone should present the Chinese data, and then I will present the Italian data.
Yeah. Your second speech.
Yes.
Okay, so now we invite Dr. Zhang Jin give a talk. Zhang Jin, can you say a few words about?
Yeah, Professor Xu, and it's Curigliano. It's my great honor to be here for the online meeting and with Professor Xu and Professor Curigliano together co-chair this conference online. So in this very special time, I want to express very welcome to everybody, and especially for the doctors overseas. I do hope in these 2 hours we can discuss more detail for the breast cancer, for everything for the patients. So I'm going to introduce the program of this online conference. We are going to have 3 parts of this conference. First of all, I'm going to introduce Professor Xu, chair the first part of our conference.
Okay, thank you, Dr. Zhang. Thank you all of you for your valuable time in this online meeting. So now I introduce the first speaker, Dr. Chao Wei from Peking Uni Medical College Hospital. Dr. Chao Wei, can you show the slide? Dr. Chao Wei is the physician of infectious disease in Peking Uni Medical College, China. Dr. Chao has focused her clinical research. Dr. Chao Wei? So she will talk about the. Can you show the Zhang Jin? Okay, so now, so she will talk about COVID-19 prevention, control, and self-protection. Dr. Chao, please.
Thank you for the introduction. This is Dr. Wei Chao from Peking Union Medical College. Perhaps I'm the only doctor of infectious diseases here. Currently, I'm still in Wuhan. And the good news is from yesterday, the lockdown of the city has been lifted. Fortunately, the life will gradually go back to normal. So I'm very honored to have this once in a lifetime opportunity to speak here in this conference. So I will briefly try to be brief to introduce what we have learned from the experiences in Wuhan about the COVID-19 prevention, control, and self-protection. So just as we know from the news and reports over the world, a new coronavirus, the COVID-19, has been identified last year. And currently, it has been a global pandemic as declared by the WHO. So from the map, we can see that the size of the circle actually depicts the number of patients that have been infected in different places or areas of the world. So basically, the US, the North America, and the Europe are now the epicenters of the epidemic, and China, fortunately, is gradually recovering from that. Since last year, the knowledge of the disease and its pathogenesis is actually growing all the time. And unfortunately, up to now, no definite effective antivirals have been found. And the high infectivity of this disease makes it extremely challenging for the global society to control this disease. And this is not the only coronavirus we have found in history. And altogether, we have 7 coronaviruses that can infect human beings. As famous as the SARS from the 2003 and the MERS episodes. The COVID-19, the new coronavirus, actually share some similarity in the chest imaging or histopathological and immunological changes with other coronaviruses, but it certainly has some distinctive presentations. Generally, it holds a longer course of disease and usually will involve broader involvement of different organs at the end stage of the disease. So now we know that the infection of the virus can include a wide spectrum of clinical presentation, including those have been asymptomatic infected, which accounts for about 20 to 30% of all the population, basically from the data in China. And then the mild type with only the upper respiratory tract illness, but no infiltration of the lungs. And then the common type with pulmonary infiltration, but no signs of hypoxemia. All these 3 types accounts for the most of the patients that have been infected, about 80%. And then we have the severe type with respiratory distress, and also the critically ill, those who need invasive ventilation or stay in intensive care unit because of other reasons of mortality failure, organ failure. What we should note is that although these 2 types only accounts for 10 to 20% of the patients, depending on where the areas is, but these are the major sources of mortality. Once a patient has entered into the critical care unit, the mortality rate is about 60 to 70% in every ICU department. These are the major populations that contributes to the overall mortality and should cause special attention. So from the knowledge, we've known that the coronaviruses actually got infected through direct or indirect exposure of respiratory tract. Most probably, it will pass through the upper respiratory tract mucosa. And different from other coronaviruses, this new virus can replicate actively in the upper respiratory tract, makes it efficiently in shedding virus in the asymptomatic or those with mild symptoms. And then similar to the other coronaviruses, it will spread to the lower part of the respiratory system and then generate secondary viremia to transmit it to all of the body. And as we all know, the major binding receptor of the coronavirus is ACE2, and this is widely distributed in epithelial and endothelial of different organs. So those organs can be easily affected once the viremia has reached all of the body, including the lungs, the heart, the gastrointestinal tract, and also the vast vasculature, mostly in the lung area. And based on these findings, we have generated a hypothetic pathogenesis of COVID-19 patients. We have observed patients of mild types and also severe and critical types. And basically, the cause can be divided into 3 clinical phases. The first week usually is a mild phase with viremia beginning, and patients also often presented with only low-grade fever and discomfort, and then entered into the second phase. Usually this is the acute phase with elevation of inflammatory markers, and also the progression of lung infiltrations may present at this time. This is the second week. And if the patient is going to deteriorate, this is the starting point, and which is possibly is a window of opportunity for intervention. And the last phase, if the patient is a mild type, it should be a recovery phase. But if the patient enters into the severe or critical type, this may be the final late stage that requires comprehensive treatment. So there has already been discovered many candidates or managements generated for COVID-19, as I listed here. I want to devote too much time to this. We know that we might have antivirals. These are the candidates, though none of them have been proved definitely effective in treating this disease. And then we have anti-inflammation. The major window of operation is the starting week, which we said was the second week when the inflammation elevates. And then the comprehensive support, most significantly when the patient has entered into the ICU. There's no magic bullet at this time. All we need is a comprehensive support. So as you may see that there's no final treatment to the disease. The basic rules for the disease control or treatment is the first important is prevention. Try to protect vulnerable people and prevent them from getting the disease is the first thing that we should consider. And then is the early intervention. If unfortunately an individual has got the disease, the most important thing is that you try to intervene, to give him intervention before he finally gets the severe or critical phase. This is a basic rules we're observing as infectious diseases. And want to talk a little bit about how we manage COVID-19 patients, as it now turned out to be relatively, and also this has been carried out in different levels. The community, the cabin hospital, and the central hospitals are doing different work and tasks. And also, at the same time of the lockdown, all the medical resources and workers, personnel are generally concentrated from all over China to Wuhan, Hubei province to help them to overcome this difficulty. And then the second is to cut the routes of transmission, which we have been done every day, the quarantine and lockdown in selected areas. And also personal protection methods have been emphasized to everyone in China for ordinary people. And the third is to protect vulnerable. This third level is realized through the above two mentioned measures. And also we are expecting the vaccine to come maybe later this year or the next year. And a little information about how we triage patients in healthcare facilities. Actually, this slide actually has been shared with the Italian experts from time to time during the online discussion. And take PUMC, for example, actually in all over China, after the year of 2003, the SARS season, the fever clinic is an ordinary setup for all the comprehensive hospitals. So basic fever clinics will be used for screening suspected patients, especially in this season. And we will do the vitals and history taken and the screening with complete blood count or chest imaging and PCR testing for COVID-19 and other respiratory pathogens at the same time. Then to decide if the patient should be sent to a designated center for COVID-19 or sent back home for observation or for other medical needs that may be carried out in the medical center. For those who are going to take or have surgeries, for example, what we will be discussing this meeting, the breast cancer surgeries, it should be necessary, if possible, to screen the patients before admission. We know that different countries and different areas are having different ways of realizing that. For example, in China, now we have a health code for each patient who want to come to PUMC hospital to have surgery or other medical care. Then from the health code, we can tell where the patient have been in the past 2 weeks and decide whether he has a suspected contact with other suspicious patients. And that is one thing that we should look at. And the other is that before the admission, necessary screening, including the chest imaging or PCR testing, needed to be done if there is a suspicion of infection. And also, after the patient has been hospitalized, the infection control measures are also important to prevent patients to get infections from each other when being hospitalized. I think this topic will be talked about a lot in the following sessions. And so then we will talk about a little about the personal protection. Based on what we have mentioned, different areas treating different patients, the protection levels in China are generally divided into the 3 levels. The first level are directed to those ordinary patients, means that patients with low risk of infection. So the physicians wearing surgical mask will be enough for working. And then we have second level in the fever clinic or emergency room with potentially infected patients, or the third level with definite confirmed infected patients. Then at each level, we will have different facilities of protection. And this has already been shared with many foreign colleagues. And I just want to mention it here because as the life is going back to normal and more and more patients of other diseases will come back to the hospital. So we should be alert with all the patients admitted for possible infected sources. So finally, this is a picture from the ward we are walking here in Wuhan. And I want to express my deep thanks for all the audience. And also I want to say to my Italian colleagues, this is a tough time and we totally agree with that and we understand that. But we will get through this all together. Thank you.
We will open discussion and questions after all presentation. So next speaker is Dr. Curigliano from Italy. Dr. Curigliano is the head of the Division of Early Drug Development, European Institute of Oncology. He will talk about the breast cancer patients in epidemic data of Italy and the management of Milan. So Dr. Curigliano, please.
Yes, thank you. Thanks a lot for inviting me. So I will present to you breast cancer patients in epidemics management, and I will show to you the data of my country. So this is the outline of my presentation. I will provide data on epidemiology in Italy that are completely different from the Chinese one, since we started containment and social isolation 3 weeks later, before the appearance of the first infected people. I will present the case fatality rate. I agree with Dr. Wei that is very high if patients will arrive in intensive care unit. And then I will present some data on COVID-19 in breast cancer patients and impact on clinical practice and clinical research. So those are the data updated to yesterday afternoon. We have a total in Italy of 1,039,000 people infected. And the number of people who died are 17,669. Is much more respect than China. Consider that 10,000 people died in my region, in the region of Milano and Regione Lombardia. This is the curve. We are going to flatten the curve here. You can see very well that is going to be flattened, the curve. So in the last days, we had less admittance to hospital and less people died. So in green, you have the dismissed people, and in gray, you have people who died. And in terms of new infected case, this was the peak, and now we are going down, finally. Consider that we have a different situation across Italy. So we are for sure going down in Regione Lombardia, but in the center and in the south of Italy, we have a little bit of more cases actually. What's about the cancer patient mortality? So we have a different population. The median age in Italy, I would like to thank Dr. Trapani who prepared this slide, and we are going to publish this table in the European Journal of Cancer. So we have a total median age that is 37 years old in China and 45 years old in Italy. But when we consider people beyond 65 years old, we have a lot of people in Italy that are 65 years old. 65% of the population is more than 65 years old. So we have a different population respect to the one area. Patient population in Italy is older. And of course, we have much more comorbidities. According to WHO, 36% of patients in Italy have cardiovascular disease, 27% have cancer, pulmonary disease in 6%, and diabetes in 3%. That's why maybe when we compare the cancer population, we have completely different data. Some case series have been published from the Wuhan area, specifically the Caucasian patient population published on The Lancet. with 9 out of 18 cancer patients with severe events, with a case fatality rate that is close to 80% if cancer patients have been admitted in intensive care unit. Looking at our data, the paper that had been published on JAMA, 155 patients has been admitted to intensive care unit, with, according to the first data, 17.3 all of the COVID deaths. So in cancer population in Italy, we have a case fatality rate of 17.3%. Yesterday, we had data published on JAMA related to patients admitted in the intensive care unit. This is a population of 1,591 patients admitted in intensive care unit in the area of Milano. And it's very interesting here. Look at the median age. The median age is between 62 and 66 years old. Most of them had a supportive care. This is very important. And if you look at the patient who died, mortality is very high. So we have a mortality that is closer to 58% in the age of 81, 90%, 50% between 71 and 80, but it's also very high in patients between 61 and 70 years old, 42%, 51 and 60 is 20%, but 19% of patients died in the age of 41 and 50. We have 0 death, it's 0 to 80, and 21, 40 years old. Looking at the cancer patients, so patients with malignant cancer or active cancer, they were 81 of all the population of 1,500, so 8%. And the case fatality rate was 20% in the elderly population, 13% between 71 and 8, 9% between 61 and 70 years old, but 4% for 51 and 60 years old, and 2% for 41 and 50 years old. So very high case fatality rate for the patients with active cancer. So what we did finally to prevent infection for cancer patients in our hospital. So we did a community mobilization, health education. We informed patients in the epidemic area. Of course, we managed close contacts. We suggested patients and health providers to wear personal protective equipment. We did a close monitoring for potential toxicity and for COVID infection symptoms. And of course, we tried to reduce access to hospital, specifically for all patients of treatment. And we tried to maintain the best of care for those patients that have treatment for curative intent. So we distinguished COVID hospital, and we generated the hub-and-spoke network. Specifically what we did in the Regione Lombardia area, we identified the 3 hospitals, cancer centers, the National Cancer Institute, my hospital that is the European Institute of Oncology, and Humanitas Cancer Center, and any patient with diagnosed cancer and no COVID infection who had the priority to receive surgery have been centralized to these 3 COVID-free cancer centers. Of course, we cannot say that we didn't have COVID patients, but it's very limited, the number of COVID patients in our hospital, because we did a lot of triage with external checkpoint, exactly like in China, relieving the body temperature, doing an anamnesis in order to reduce the potential contacts with infected people. And actually this model is working. What we did is to generate adapted guidelines for outpatients, for surgical patients, and for patients in the early breast cancer setting and the metastatic setting. So we defined high priority for surgery, any post-operative unstable clinical scenario. So if you have an hematoma or an infection following breast surgery, this was considered a high priority. and also an outpatient visit for breast cancer diagnosis during pregnancy. Then we had high medium priority, do diagnosis of invasive breast cancer or on-treatment patients with new symptoms. Medium priority were post-operative visits in patients with no complication or new diagnosis of non-invasive cancer like the CIS, so convert as many visits as possible to telemedicine. Low priority were follow-up, survivorship, and screening. Going to diagnosis, we define it as high priority, a self-diagnosis of breast lump, or a clinical evidence of local regional relapse, or pathology assessment for abnormal mammograms, BI-RADS5, or breast symptoms or asymptomatic metastatic relapse. Medium priority with BI-RADS5 or initial metastatic workup. Of course, we had a lot of low priority. In most of the cases was the screening. What's about surgery? High priority was breast cancer surgery complication or complication of reconstructing surgery like ischemia, or surgery for patients who completed neoadjuvant chemotherapy-based, surgery in patients with invasive breast cancer for whom the multidisciplinary tumor board may decide to proceed with upfront surgery, and breast cancer surgery during pregnancy according to stage and biology. Was defined as medium priority, a clinical low risk breast cancer. Let's assume ER positive stage 1 for which you can start endocrine therapy. Discordant biopsy likely to be malignant, and low priority were all the CIS, fibroadenoma, papillomas, discordant biopsy likely to be benign, or breast reconstruction and prophylactic surgery. In radiation therapy, we gave high priority for symptomatic management of symptoms, for acute spinal cord compression or symptomatic brain mets, and for radiation therapy in high-risk patients, so inflammatory disease and node positive, very young patients. Medium priority for low intermediate risk breast cancer, and low priority for elderly population with low risk ER positive, where you can start adjuvant endocrine therapy. Moving to medical oncology, we tried to maintain the best of care for those patients. Of course, as you recommended, if indicated, we did the screening for COVID infection, but we believe that high priority should be neoadjuvant chemotherapy for triple negative and HER2 positive disease, continuation of TDM1 and capecitabine in the post-neoadjuvant setting, and in any case, if the patient is in a clinical trial, provided patient benefit outweigh risk, of course, we tried to maintain patients that already started a clinical trial. For the older patients, medium priority or low priority, so try to give oral treatment to reduce access to the hospital, and in case of low risk according to biology or genomic signatures, just give endocrine therapy for those patients. In the metastatic setting, we gave priority to HER2 positive breast cancer because we know that they may derive a benefit in terms of overall survival. Another priority was visceral crisis. And for medium priority were second, third, on beyond third line therapy. Avoid mTOR inhibitors and PI3 kinase inhibitors. And again, when you have to deliver bone agents like zoledronic acid or denosumab, try to delay or to give every 3 months. In terms of impact on clinical research, of course, we generated a lot of protocol deviation and protocol violations because we missed visits, we missed biopsies, we missed CT scan. Of course, we had guidance of FDA and European Medicines Agency. And I have to tell you that many of the pharma companies tried to submit a lot of protocol amendment in order to have much more compliance to protocol reviews. So we are still in the middle of epidemics. I would like to thank a lot the Chinese government, because they gave us a lot of suggestions in terms of medical and public health advice. I am member of the National Health Council, and you shared with us everything you did, but also practically, because many doctors from China came in my country. They are actually in Milano, in the Cremona area, to advise us, to say us what we have to do. And practically, you gave us a lot of personal protective equipment. So you share it with us, your personal experience in terms of high-level knowledge, and those practically you gave us money and personal protective equipment. So really hands in hands to battle this COVID-19 infection. Really thanks a lot for what you did.
Including diagnosis, treatment, and clinical research. So the next speaker is Dr. Liao Ning. So Dr. Liao Ning is a professor and a director, Department of Breast Cancer Center, Guangdong General Hospital. I think her topic is Chinese wisdom for breast cancer patients treatment during 2019 coronavirus outbreak. Dr. Liao, please.
Thank you,
Oh, sorry.
Chair,
Oh.
friends. And I prepared a video for this topic. And please. I'm Dr. Liao Ning. I'm from Guangdong Province People's Hospital in southern China. In the past 3 months, the rapid spread of COVID-19 virus from Wuhan to Hubei and the whole country has caught everybody off guard. Led by Dr. Yuxie Qing, the director of our hospital, as the designated epidemic hospital of Guangdong Province. Our colleagues fight the epidemic together. A group of people resolutely stand in the front to build a line of protection to protect the lives and health of people. They are the most beautiful countermatch people. Let us applaud them, like them, and cheer for them. COVID-19 is highly transmissible and highly susceptible to the cold, which seriously threatens the lives of the general public. At the same time, the COVID-19 pandemic also poses a serious threat to cancer patients. This is a study published in February 2020 in Nature Oncology. As of the data cut off on January 31st, 2020, 1,590 COVID-19 were included in 575 hospitals in 31 provincial administrative regions of China, of which 18 had a history of cancer, which is higher than the incidence of cancer in the overall Chinese population. COVID-19 patients with cancer were observed to have a higher risk of severe events. The risk was also higher in cancer patients receiving chemotherapy or surgery. Cancer patients with COVID-19 infection progressed faster and more promptly became the severe cases. Cancer patients and those with weakened immune systems are generally more susceptible to COVID-19 virus, and their infection progresses more rapidly during this pandemic. Chinese wisdom and experience for managing breast cancer patients is particularly important. In order to ensure the safety of both doctors and patients with breast cancer, as well as the quality and effectiveness of their treatment, experts organized by Guangdong Province, the Hospital Department, Breast Surgery have organized a medical quality control center. and established the guideline for protection and quality control for strengthening the prevention and control of COVID-19 infection in breast surgery in Guangdong province. I'm the member of the guideline expert group. On the basis of these guidelines, the Department of Breast Cancer, Guangdong Province People's Hospital initiated a series of measures and processes to scientifically manage the diagnosis and treatment of breast cancer patients during the pandemic. The first step is to actively carry out an online diagnosis and treatment plan to reduce the risk of patients going out for medical treatment. The WeChat mini program. The online clinic of the Department of Breast Cancer of Guangdong Province People's Hospital is now available. Patients can use the WeChat to consult with the doctors online, thus reducing long-distance travel, staff turnover, and repeated visit, and as a result, reduce the risk of COVID-19 infection. This program allows the patient to choose the nearest medical institution that can meet their medical needs and have a convenient clinic to conduct inspections and tests. The doctors can inform the patients of the results online or by phone and will assist in the treatment planning. We have established Professor Liao Ning's breast cancer molecular consultation platform every Wednesday to broadcast a molecular tumor board since 2019. When the pandemic came, we further optimized the program. This program is not only a professional online learning platform for doctors, but also a live Q&A activity for patients. I host a live broadcast from the 6 to 8 p.m. every Wednesday evening. I invite Professor Charles Bauch, who is the president of the cancer expert now international and the past president of the American Society of Surgical Oncology and visiting professor of Guangdong Province People's Hospital. Professor William Bradshaw, who is the chairman of the NCCN Breast Cancer Guideline Committee, and Professor Susan Kimberlin, who is the past president of the American Association of Breast Surgeons, and Professor Hope Rugo, who is the executive vice president of the Cancer Expert Now International Panel, and Professor Armando Giuliano, who is past president of the American Society of Surgical Oncology, and other world-class experts. All of these, the breast cancer experts from the United States, are members of the Cancer Expert Now International. Experts in breast cancer and experts in tumor gene molecular tests are also included on this elite team. Together, we will provide breast cancer patients with consultation with accurate and scientific treatment solutions. When patients have medical problems that cannot be addressed by online consultation, must be seen directly, strict prevention and control measures must be taken for those patients who have to visit the Guangdong Province People's Hospital. First of all, patients can enter the hospital area until their temperature is measured by infrared rays. Patients must have their temperature measured by hospital protective staff before the outpatient consultation and must wear a mask before admission. For patients with fever, cough, dyspnea, etc., or history of recent travel to Wuhan, history of contact with people in Wuhan, or patients with COVID-19, customary onset, etc., the full-time staff wearing the protective gear will direct the treatment. patient can only be admitted to the ward after demonstrating a negative COVID-19 as confirmed by 2 times of nuclear exit testing and a chest CT scan. Rules of engagement for admitted patients. Arrange the beds reasonably, pay attention to the isolation of the beds, and try to arrange one room for one patient. A chest CT examination is required for routine admissions. Medical records should be standardized, and the epidemiological patient history during the epidemic should be added. Except for specialist examination, check for respiratory and gastrointestinal discomfort and accurately record the body temperature. Monitor body temperature twice a day and ask if there are any respiratory symptoms. If there are new suspicious clinical manifestations, then nuclear exit testing and repeat chest CT scan should be arranged as soon as possible. Chemotherapy, target therapy, and endocrine therapy are important methods for breast cancer treatment. It is recommended that the treatment program should be appropriately adjusted during the epidemic, and either postponing inpatient treatment or arranging treatment nearest the patient's home if necessary. For hormone receptor HR positive breast cancer patients receiving endocrine therapy, try to prescribe long prescription during the pandemic and continue their treatment at home. If high-risk patients need ovarian function suppression, a long-acting preparation can be used every 3 months as appropriate. However, if target therapy is not administered for more than 3 weeks, the loading dose should be re-administered. Rules of engagement during surgery. Protection should be implemented according to the primary protection requirements. During the operation, surgical staff should wear operation caps, medical surgical masks, protective medical shields, disposable isolation gowns, and disposable gloves. In addition, medical protective masks, protective clothing, protective face screen, and protective foot covers should be selected according to the exposure risks. When using high-frequency electric knife, ultrasonic knife, and other energy platforms during the operation, a pressure suction tube should be used to suck the smoke generated during the operation, so as to prevent the patient's body fluid to splash or indoor aerosol to accumulate. Rules of engagement during patient transfer. Protection should also be taken during the transfer of the patient. Follow the designated route of the hospital to enter and exit the operating room from the special channel. Patients should wear disposable surgical masks and cover the whole body with a single disposable surgery sheet. A special staff will clear the transfer channel in advance to reduce the exposure of unrelated people and environmental pollution.
More than 900,000 cases of COVID-19 have now been reported to WHO from almost every country in the world. That's heartbreaking. The pandemic is accelerating, but we are not prisoners to statistics. We are not helpless bystanders. Working together, we can change the trajectory of this pandemic. In this difficult time, for cancer patients, for breast cancer patients, we not only fight this pandemic in the strongest terms possible, but also help them to move forward in their life.
Thank you, Dr. Liao. Okay,
Thank you.
success.
Thank
Okay,
you.
thank you, Dr. Liao. It's a very, very nice video presentation. So, are you going to say a few words for your nice presentation?
Thank you, Chair, and good afternoon on this Thursday. I think that today that we are in the unprecedented global crisis. The world is far from the world in this coronavirus 19 world. So one side we fight the virus with our efforts, but the other side we need to take care of our cancer patients and the breast cancer patients. So this is the goal that we work together today. So I think this is the same goal. Thank you, every colleague, especially thank you, Professor Curigliano from the Italian, and thank you, our chair, Professor Xu and Professor Zhang.
Thank you. Thank you for your nice talking. So last speaker, first part is Dr. Feng. He came from Department of Breast and Steroid Surgery, Renmin Hospital, Wuhan University. He's going to talk about what to do for breast cancer patients in Wuhan under the epidemic of COVID-19. Dr. Yao, please.
Okay, thank you. So can everybody see my screen?
Oh, yeah.
Okay. So hello, everyone. Good afternoon or good morning, wherever you are. I'm Feng Yao from Department of Breast and Thyroid Surgery, Renmin Hospital, Wuhan University. I would like to thank for giving me this opportunity to share some information in terms of the epidemic of COVID-19 in Wuhan and the situation of our breast cancer patients. So here is the outline of my presentation. So the epidemic of COVID-19 was approaching before the Lunar New Year holiday. Wuhan is the epicenter of China's epidemic. Airports, train station, and highways was closed at 10 a.m. January 23, the day before Chinese Lunar New Year. So as you can see from this picture, the Hankou station in Wuhan is locked down for the first time in its 121-year history. As the virus spread rapidly, public transportation of Wuhan was closed as well. So this photo showed from this photo, you can see rare pedestrians in Wuhan streets, occasionally see cleaners. As you know, this is the Chinese holiday season, but it was demonstrated that forced quarantines did cut both the number of peak active infections and the predicted total number of infections by the end of the epidemic. So since the lockdown began, the city's hospitals have been completely swamped by patients, confirmed and suspected with both severe and mild symptoms. Some hospitals have had to establish makeshift fever clinics inside small community clinics without the necessary equipment to identify whether feverish, coughing patients are suffering from the novel coronavirus or just a common cold. So as you can see from this picture, a crowd of patients surround the hospital worker inside an outpatient fever clinic. Almost every hospital suffered severe shortage of personal protective equipment, diagnostic tools, medical staff, and laboratory capacity. So this picture showed patients packed the hallways of the Red Cross Hospital in Wuhan on January 2022 because of designated hospitals' shortage of hospital beds. So at the very beginning of the outbreak in Wuhan, self-quarantine was required for mild symptoms cases. They had to go home to isolate themselves from family members. So as the number of confirmed cases increased rapidly, more and more hospitals were recruited to become designated hospitals. Meanwhile, the government decided to build 2 quarantine hospitals promptly. It was amazing that it just took about 1 week to finish. So COVID-19 is generally diagnosed based on combination of clinical symptoms and lab tests, depending on the conditions, testing availability, and the prevalence of the disease in the environment. In middle February, facing a backlog of cases and long wait times for tests in Hubei, authorities changed the diagnostic criteria for COVID-19 in Hubei province to allow confirmation via chest CT scans without lab tests. It appears to have been an attempt to prioritize treatment over diagnosis, where hospitals were overrun by COVID-19 cases, and it was reversed in the next round of guidelines. I would like to point out here that the establishment of shuttle hospitals was a very bold and effective strategy dealing with the shortage of hospital beds. Wuhan authorities had converted 11 venues, including gymnasiums, exhibition centers, and sports centers. The Wuhan experience did show that no-tech shuttle hospitals allow patients with mild symptoms to receive less intensive forms of care while remaining isolated from other people, thereby reducing infections and concentrating medical resources where they are most needed. Actually, this approach changed the course of the rapid escalating pandemic. So for the first 10 days after the city was put on lockdown from January 24th to February 2, we focused on treating patients in severe or critical condition and allow suspected cases to stay home and quarantine themselves. The city's capacity to test the people was slowly increasing, but still very limited. Many of the suspected cases were indeed infected patients, but without confirmation, they were unable to receive treatment. Access to treatment is critical when dealing with COVID-19, which develops quickly and can leave a patient in severe or critical condition in a matter of days. That was why the mortality in Wuhan is higher than those outside Hubei province. So on February 2, a critical decision was announced that aimed to finally get things under control. The city government decided to quarantine everyone who fell into any of 4 categories: infected, suspected, patients with fever, and close contact. So as you see above, the classification, the classified admission. So the confirmed cases with obvious symptoms will be admitted to designated hospitals. The confirmed cases with mild symptoms will be sent to shuttle hospitals to quarantine. And for those suspected cases, they will be sent to the hotels to prevent the cross-infection. So as the number of beds increased, the lack of medical staff became a serious problem. Many healthcare providers were extremely overworked. They were suffering burnout. Chinese government decided to deploy of healthcare workers nationwide to Wuhan. So finally, we achieved the goal of hospitalizing all confirmed infected patients and testing every suspected cases of the virus. So as I mentioned, that many hospitals was recruited to the COVID-19 designated hospitals, and some oncologists were dispatched to care those virus pneumonia patients. The treatment of lung pneumonia patients, including breast cancer patients, was suspended. The city government strengthened management and control of personal mobility, which had a great impact on the examination and treatment of breast cancer patients. No public transportation, and going out by driving a car was also prohibited without transfer permit, which was issued only to those frontline workers. Enforcing mandatory quarantines and travel restriction nationwide made it impossible for patients going outside of Hubei province to receive cancer treatment. Some patients whose appointments had not been canceled are scared to go out because of their systematic immunosuppressed state caused by the malignancy and anti-cancer treatments, such as chemotherapy, targeted therapy, and immunotherapy. So here, this is a study undergone by our colleagues of Zhongnan Hospital, Wuhan University. It did show that the patients with cancer have twofold increased risk of COVID-19 in comparison to the general population. So as you can see from this study, I remember that Dr. Liao has mentioned at her presentation, COVID-19 patients with cancer might have a higher risk of COVID-19 than individuals without cancer. Additionally, compared with patients without cancer, it shows that patients with cancer had poorer outcomes from COVID-19. So this slide just shows the delayed therapy of early stage breast cancer, such as delayed initiation of neoadjuvant and adjuvant chemotherapy. Neoadjuvant or adjuvant chemotherapy forced to stop temporarily, or delayed surgery, delayed adjuvant radiation therapy. So what we have done for our breast cancer patients, our breast cancer patients actually encounter challenges from both anti-cancer and prevention of virus infection. So guidelines in breast cancer under the epidemic of COVID-19 were composed by several Chinese prominent experts promptly. The chairman of today's webinar, Professor Xu Binghe, is one of the chief editor of the first guidelines. So I think that Professor Liao has already showed us the content of the guidelines in her presentation. So we can follow the above the guidelines during the pandemic. Meanwhile, decision-making on whether or not to postpone cancer treatment need to be individualized based on each patient's respective status. So as we know, breast cancer patients would be more vulnerable to potentially having severe disease or having complications resulting from an infection. So during this epidemic, in addition to better protection, patients with breast cancer need online medical counseling and appropriate identification and treatment of critical cases. Our breast cancer committee of Hubei Society of Clinical Oncology organized the prominent breast cancer experts to provide online medical services to our patients. We also provide counseling to patients through social platforms such as WeChat. The epidemic prevention situation of inhabitants, the disease stage, and the previous therapeutic schedule being taken into account for, the most appropriate decision could be made after professional discussion and communication between doctors and patients online. So one of our initial priorities was to establish a multi-layer coverage system for the clinics. My hospital determined that all visits for existing patients would be transitioned to telemedicine. We have rapidly expanded telemedicine efforts through expedited physician credentialing, training, and modification. We also underwent a psychological investigation of breast cancer patients under the epidemic of COVID-19. Here are our data under review. As you can see, treatment discontinued, as you can see here, or the delay of breast cancer therapy increased the anxiety and the depression significantly. So that is why we think psychological counseling for cancer patients should be paid more attention to. Actually, at the same time, our colleagues of psychiatry department also provide online counseling to our breast cancer patients. So the next, I would like to show what we have done for our healthcare workers. At the very beginning of the outbreak, as the number of the confirmed cases increased rapidly, many healthcare providers were extremely overworked. They were suffering both physical and mental overdraft. They could be psychologically stressed. So here, this is a survey done by my colleagues of the psychiatry department. Factors associated with mental health outcomes among healthcare workers exposed to coronavirus disease. It has been accepted by JAMA. Participants of this survey reported experienced psychological burden, especially nurses, women, those in Wuhan, and frontline healthcare workers directly engaged in the diagnosis, treatment, and care for patients with COVID-19. So another unpublished online survey also showed around 1/3 of 300 respondents, all of them served as frontline medical workers in Wuhan. They also experienced some kind of psychological issue. So our breast cancer committee of Hubei Society of Clinical Oncology decided to offer some help for breast physician of Hubei province. So we invited Professor Yang from psychiatry department of my hospital to provide psychological counseling for breast physician online on March 7th, 2020. So the COVID-19 pandemic has presented unique challenges and learning opportunities for our cancer care providers. Related real-world study startup, what I'm showing here is an inclusion criteria of real-world study of early breast cancer diagnosis and treatment models under the epidemic of COVID-19, initiated by Cisco BC, the Chinese Society of Clinical Oncology Breast Cancer Panel. Hopefully, we can learn more from this study, which could benefit our future work. So, the epidemic of COVID-19 in Wuhan has been contained efficiently. As the risk of catching the virus recedes, Wuhan is now cautiously navigating a path back toward normality. So what we most concerned right now is asymptomatic carriers. Asymptomatic infections are one of the mysteries of the new coronavirus. We don't exactly know what portion of infected people have mild or no symptoms and might be passing the virus on to others. This could be a great challenge. There is still controversy in terms of the contagiousness of asymptomatic carriers. So what I'm showing here is the principle. It's the principle we need to follow in our clinical practice at my hospital right now. Every patient without virus pneumonia symptoms who need to be hospitalized to receive treatment should undergo blood analysis, CT scan of chest, nucleic acid test, and antibodies test, including the IgM and IgG. Those with all negative results could be sent to inpatient department where they will be arranged separate rooms and receive the second nucleic acid test. 1 or 2 days later, if everything's okay, they will be transferred to common ward to receive further treatment such as surgery. Since cancer care are at increased risk for coronavirus infection, as chance of acquiring infection at workplace are higher. So we need to protect ourselves by putting on personal protective equipment. Outpatient department, as you can see here, an observation ward of inpatient department, we needed N95 respirator, protective gowns, goggles, and gloves. For the common ward of inpatient department, surgical mask, gloves, and the surgical gowns should be okay. So after spending more than 10 weeks on the lockdown, Wuhan opened its doors now. Hopefully, we will have a chance to meet face-to-face in the near future. But as you can see in this data, as the virus continues to spread globally, to suppress and control the epidemic, countries must isolate, test, treat, and trace. It is time for everyone to think globally and act locally to ensure that our intervention is relevant, appropriate, and right in action. So I would like to thank all staff on the front lines especially those who came to Wuhan to help us for combating COVID-19, such as Dr. Cao Wei. Thanks to Dr. Chen Chuang and Li Juan for their generous and diligent contribution. Thanks for your attention.
Thank you for Dr. Chao for sharing your experience in care for breast cancer patients in Wuhan. So now I should move to the next session. I would like to invite Dr. Yang Jin from First Phoenix Hospital in Xi'an Jiaotong University. Dr. Yang will chair this open and discussion session. So Dr. Yang, please. Dr. Yang Jin. Okay. Dr. Yang. Dr. Yang. So we have four doctors join this session. Dr. Song from Fujian Hospital, Dr. Trapani from Italy, Dr.
Trapani.
Trapani.
Yes.
It's very difficult to pronounce.
Yeah, good afternoon to everybody. May I just start the discussion with you? Can we start if you agree? This is okay. Dr. Trapani from Milan. Okay, I just really want to open a discussion with the board and you experts of breast cancer and COVID-19 in China. As Italian, I really appreciate all your role and expertise to share with us because that's really a precious information for us. We can really learn a lot in these very hard periods of our healthcare. So the discussion that I would like to share with you is about the testing policy for SARS virus for cancer patients. Because if I well understand, multiple of you, many of you have said that you generally provide a PCR, so a test for the virus and a CT scan of the chest to all the patients before starting the treatments. So my question is if this is done for every access of the patients to the institution, meaning if a patient receives a treatment each 3 weeks, do you provide the viral assessment and the CT scan every time, or just for specific patients with symptoms of fever or in very specific situation, for instance?
Who wants to answer these questions? Dr. Liao or Dr. Dr. Yao?
Actually, right now, as you mentioned, the patients will come back to receive the such as the chemotherapy every three weeks. So at every time when she will be admitted to a hospital, she will receive the routine chest CT again, and also the nucleic acid test again. Because as we know that the symptom carriers is really mysterious. We did find several patients when they came back second time, we found that the nucleic acid test is positive or positive.
Can I ask a question for Dr. Yao, Dr. Wei, regarding specifically the monitoring of the post-infection scenario? So are you testing people that actually are asymptomatic and had the previous infection, determining IgG and IgM in the serum in order to identify those that are immunized? And eventually, which is the time of seroconversion? And do you believe immunity is permanent or transitory? It's a very complex question, but we have to understand what we have to do now in Italy.
So yes, exactly. So you know, the first negative rate of nucleic acid test is, I mean, it's obvious. So that's the reason why we recommend to test the IgM and IgG antibodies also as well. So you know, if the the nucleic acid test is negative and the IgM is positive, it suggests that the patient might have been infected with the virus and it's the early stage of the disease.
Yeah.
And Dr. Wei, can you comment on this, because you are an infectivologist and maybe you can give us more advice, because now we are approaching this new phase with a lot of tests. So the question is, are they useful or not? Can we do something like an immunological ID card to tell the people, okay, you are immunized, you can go back to work, you can come to do any type of treatment? And finally, another question is, which is, in your opinion, the time of immunity that you acquire for this virus? Do you have any information? You are the first to face, so maybe you know something that we don't know.
Yeah, maybe I can add a few words in addition to the above answer. So the seroconversion time of the COVID-19, right now, the current data suggests that the positivity of IgM will begin to appear in the first week, normally 5 to 7 days. And then the IgG will turn not a few days apart from IgM. And then the two kind of antibodies will coexist for a certain period of time, usually 2 or 3 weeks, but we are not sure when the IgM will finally disappear. Basically, the positivity of these antibodies will suggest you have an infection, but the positivity rate is different based on the time of test. For example, if in the first week, now the current studies have suggested that the positivity of PCR testing should be most probably to get a positive result, because the shedding of virus should be in a large amount in the first week. But after the first week, the positivities of testing upper respiratory samples will decrease by PCR testing. At this time, the sensitivity of IgM and IgG testing will begin to increase and last for a certain period of time. So in China now, we are actually combining these different measures of testing, including the PCR, and in some places, antibody is a routine. And also, chest X-ray or chest CT scan should be combined together, because we now don't have the capacity to tell when before the patient came, when exactly the patient is in during his disease course. So probably you will need to combine different methods of testing. And also in different places in China are beginning to having the serological screening of individuals or normal people to see what's the ratio of like asymptomatic infected patients and other patients to determine the level of infection in China society generally.
And another short question, because it's not so easy to discuss directly with you. What's about the risk of reinfection? Because I know that actually you are approaching also potential reinfection of people that have not been cured perfectly, and so they have a new risk of being reinfected. I remember a case report from South Korea. Did you observe someone who has been reinfected or not?
Yeah, there has been some discussions about the reappearance of positivity of PCR testing after the patient has been discharged or apparently been recovered from the previous illness. I have to say this is a new disease, and still we have very limited information about this disease. But currently what we observed is that those patients who began to show, who turned positive again as regards PCR testing did not have the same symptoms or disease cause again. Most of them are asymptomatic and without exaggerating of the respiratory symptoms. So most of the experts here may believe this must be some, may not be an intact virus actually you are testing. And based on the past knowledge of acute respiratory infections caused by virus, I believe a recent reinfection is not very probable because from the previous knowledge of other respiratory diseases caused by virus, it is nearly impossible to have a reinfection in a very short time.
So sorry again for Dr. Wei, our infectious disease expert. I really agree, and I really like your response. Of course, it's hopefully we hope it's not going to be back in this way, this specific respiratory syndrome. Because as you know, I mean, definitely better than us, this RNA virus as a polymerase that is really error prone. So far we have described a lot of strains and variants of the virus. So my question is, if we demonstrate serological conversion with IgM and possibly protective IgG, what about for these new emerging strains? Because when we study the phylogenesis of this virus, it's really complex. There are a lot of mutations, and some of them can definitely define an escape of the immune response for a possible new strain. Do you believe this kind of new coronavirus are just less morbid? I mean, they will result in a less severe disease. And what have you observed so far in the reinfection cases?
I really don't have data for your question. That's a good question, though. So the first point I want to make is that those who have been to show re-positivity or reappearance of positivity of PCR testing are now not defined as reinfected cases. So the shedding the positivity of PCR testing could be positive also for the previous coronaviruses. For example, in the SARS season, after the patient has been recovered for 1 or 2 months, the PCR testing from the fecal samples are still positive for the patients, recovered patients, which does not mean the patient has infectivity or the patient still have the disease. So coming back to the new coronaviruses, it is also possible that you may observe a positive PCR testing result, but the PCR testing positivity does not equal to infection, because this could be pieces of virus instead of an intact virus. It also can be differences of different sampling skills between 2 different samples. So it really needs more data or long-term observation to determine what's the significance of this group of patients. But now, most of the patients who turned positive again did not show again the symptoms or disease cause as we observed for the primarily infected patients. Also, we haven't observed infectivity of these patients up to now, but still this is only a short-term observation. We may need long-term data for that. I actually don't know what will turn out after the patient has been immunized for this kind of strain of coronavirus when he or she will be confronted with another kind of strain. But the possibility is that either the patient will not get easily infected again or presented with a decreased severity of symptoms according to the knowledge of previous viral infections, including influenza. That's my supposedly answer, yeah.
So I have another question because, you know, I believe your country gave a lesson of public policy for all over the world. You contained the infection in a very short time. You took a decision as soon as possible, and also you concentrated the resources, competence, and people in a very short time. It's impossible to do this in a European country and also all over the world. My question is for Dr. Liao, because I heard from you that any patient coming in the hospital will do swab with PCR and CT scan to understand if he is infected or not. So in terms of cost, of economical cost, so you had no limitation to do this. This is my question, because, you know, in my country, we are a national health system and we cannot do this for all our patients. So this is an exceptional measure that you took, or you did this without an exceptional measure?
So they also not. I think time is discussion. Time is over.
Okay,
Sorry,
you're exactly right. So a different country, different area, we have different measures. So as you say that maybe our measures will not be applied to the other areas such as Italy and the United States. Yeah, you are exactly right. It depends on the. It should be based on the individual situation. And the different situation. Yeah.
I think the time is limited, so we need to move next session. So I'm very pleased to invite Dr. Zhang from Tianjin Cancer Hospital. She will chair next session. So Dr. Zhang, please. Zhang Jin.
Okay, Professor Xu, everybody, we are going to move to the second part. In this part, we have 2 cases, and we have 2 doctors it's going to present those 2 cases. First doctor is from Guangdong People's Hospital, Professor Li. This case is about the early stage breast cancer. So very welcome, Dr. Li.
Okay.
Dr.
Here,
Li.
Professor Zhang and Professor Xu, thank you for your invitation. And also thank you for Professor Liao Ling's guidance. I'm Dr. Li from Guangdong Provincial People's Hospital, Department of Breast Cancer. And the case for today is an early stage breast cancer patient. And it's also a very valuable opportunity for me to learn and further discuss with you about the treatment during the pandemic. First of all, this patient is a 69 years old female with postmenopausal, and she discovered lump in the right breast for 1 year in our hospital and come to our hospital, and she has no family history of breast cancer or ovarian cancer. The ultrasound showed the solid mass of 2.9 centimeter at 12 position, and it's 1.2 centimeter from the nipple, and considered by RAS grade 5. and we observed no enlarged cerebral lymph node is observed. The mammography showed a symmetric opacity in upper outer quadrant. The MRI indicates a lesion of 3 centimeter in right breast, direct grade 4, and we also observed no enlarged cerebral lymph node. So this patient later received corneal biopsy, and pathology was infiltrated ductal breast cancer, histologic grade 2, non-specific type.
李教授可以听到吗？打断您一下，您的 PPT 没有翻页，我们看不到。
Okay, I will share again. Share again.
Yeah.
Can you see it? Can you see it?
No, no.
Okay, I will share again. I'm sorry. Can you see it?
现在你播放一下，全屏播放。
We can see the slide. Yes, now we can see.
帮我全屏，怎么全屏？
您共享的时候共享电脑屏幕，不要共享单个的这个文件夹。
Yes. So I will go on with this case. I can't make the screen very, so I will go on with this page.
Yes, you can just make this model and go on.
Okay.
Okay.
And the corneal biopsy in right breast, we can see the infiltrated ductal breast cancer, histologic grade 2, and non-specific type. And later on, she underwent right breast mastectomy and plus right cerebral lymph node biopsy. The pathology also shows infiltrated ductal breast cancer, histologic grade 2, and non-specific type. The tumor size is 2.3 centimeter. And we also observed no metastasis in her right sentinel lymph node. The immunohistochemistry shows ER3 positive 100%, PR1 positive, HER2 negative, FISH negative, and Ki67 10%. And the subtype comes to luminal B, HER2 negative, and the stage would be T, PT2N0M0. As just now, Dr. Zhang and Dr. Liao mentioned just now, the COVID-19 patients with breast 19 infection also progress faster. This patient need adjuvant therapy as she is a 69 years old female and luminal B subtype with stage T2N0M0. To better identify these patients' genomic assay, we perform the memory and blueprint with this patient. And we observe high and subtype group. And this is the real optional subtype of memory print and blueprint. And we can see this patient PR has no expression T6 10%. According to the AJCC guideline, it comes to luminal A type, but in Cisco and Sagalin subtype, she is So we can see this patient, the blueprint was used to better define the ER test with the ER function measurement. The mine deposited grade, so
Sorry, we cannot hear him. There is no audio.
I'm trying to share again. Can you hear me?
We can hear you, but not the speaker.
I'm so sorry, but can you hear me? Can you see the slides? Can you see the slides? Hello.
And Professor Zhang Jing maybe invited the second speaker give the presentation and let the Dr. Li Zhuhui and he address the PPT and the signal. Maybe
Yeah,
better
I think so, Dr. Liao. Yeah. So we
not
are going to move to the second cases, advanced breast cancer disease. So the next speaker is Dr. Liu from Tianjin Cancer Hospital Breast Cancer Department. So very welcome, Dr. Liu Yang.
我先將個 PPT 先。
佢依家係咪換緊下一個講者先？
係。
你应该在这儿把这个播放了。对，不是点上再播放了。对，点。播放。播放了。放映。
Good afternoon, professors, and thank you so much for giving me the chance to share a case of metastatic breast cancer. So the patient is a female and 45 years old, and the chief complaint is a mass in the right breast for 1.5 years. And the history of the breast illness is that the patient has admitted to the hospital for the first time because of a mass in the right breast, and for 1.5 years. And the examination has found multiple masses in the right breast and enlarged right axillary lymph nodes and the right supraclavicular lymph nodes and the liver mass. And we gave the patient the right breast biopsy, and the result is the right breast invasive carcinoma, and the ER 80%, PR 90%, HER2 1+, and Ki67 20 to 40, and the CK56 is less than 1%, and the EGFR less than 1%, and AR 70%. And we also gave the patient the puncture of the liver masses, and the result is a poorly differentiated adenocarcinoma, and the ER 80% and the PR 10% and the HER2 1+. And it is considered the breast source supported. And the diagnosis of the patient is the first is an invasive carcinoma for the right breast cancer. and the clinical stage is stage 4. And the second diagnosis is liver metastatic carcinoma. And also some other examinations. In the mammography is a right breast mass considered cancer, and the multiple enlarged right axillary lymph nodes considered lymph nodes metastasis. In the ultrasound shows the multiple right breast masses and considered multifocal breast cancer, BRAS 5. And also, it found the metastasis of the enlarged lymph nodes in right axillary and the metastasis of the right supraclavicular lymph nodes, and the mass in the left lobe of liver, suspicious metastatic tumor. And also, the CT shows a low density mass in the left lobe of liver, and enhanced MRI of the liver has shows a space-occupying lesion in the left lobe, considered metastatic tumor. And PET-CT has found the first, the multifocal right breast cancer, and second, the multiple enlarged right axillary lymph nodes, and the enlarged supraclavicular lymph nodes, and the enlarged lymph nodes under the pectoralis minor muscle, and also enlarged internal nodes, considered metastasis. And the third result is a liver metastasis. And ECT has found no bone metastasis. It's all the examinations. And we give the patient the treatment. First, we give the chemotherapy of the TE regimen for 2 cycles. And the evaluation of the chemotherapy effects is SD. So we continue the treatment for 1 cycle. And after one cycle, we evaluated the chemotherapy effects, and it shows the PD. So we have changed another regimen. We have given the patient the palbociclib and combined with the letrozole and glycerin. And we have given the patient for 6 cycles, and we evaluated the patient's effects every 2 cycles. And this form has shows the change of the patients, and the baseline is just before all the treatment. And also after 2 cycles, we can see after 2 cycles of TE regimen, and the primary tumor and the lymph nodes and the liver metastasis tumor size is all decreased a little. It let the SD. And just to continue 1 cycle of the TE regimen, you can see the size of the primary tumor, lymph nodes, and the liver metastasis has enlarged. So we have changed another regimen, and the regimen is for the palbociclib and combined with the letrozole and the glycerin. And the first 2 cycles, you can see all the size of the primary tumor, lymph nodes, and the liver metastasis, and it has decreased. And also after 4 cycles, because after the 4 cycles, the patient has refused to do the ultrasound of the breast, so we only did the MRI of the liver. You can also see the size of the liver metastatic tumor has decreased. And after the 6 cycles, and you can see all the size of the primary tumor and the lymph nodes and the liver metastasis has decreased almost half. So now the treatment. So our question is that how do you think about the choice of the palbociclib for the metastatic breast cancer, and also the next treatment for the patient? Thank you so much.
Okay. Thank you, Dr. Liu. So can we move back to Dr. Li for the early stage breast cancer cases? Dr. Li, is that okay?
Yes, we are ready.
Okay, Dr. Li, go ahead.
Yes. So can you see my slides?
Yes.
Okay. The case for today it's a case of early stage breast cancer, and it's a valuable opportunity to learn and further discuss with you with the treatment option during the pandemic. And this patient is a 69 years old female, postmenopausal, and the patient discovered lump in the right breast for 1 year.
So Dr. Lee, you don't have to go to the beginning. So just go ahead.
Just
okay.
Go ahead.
You don't have to move to the beginning. Okay.
Here comes to the question that does this patient need adjuvant therapy? So this patient is a 69 years old female, and considering her subtype is nominal B, and the stage is T2N0M0. So in order to add greater precision beyond clinical and pathology methods, we performed memory print and blueprint in order to guide the therapy decision. So we can see this is a composite view of functional subtype of memory print and blueprint. While the memory print is a strongly prognosis true, certified patients are carried to good signature. We also see a nominal type of blueprint are deemed to nominal A for the low risk patient population, but nominal B are associated with high risk. I don't know, you have just heard before, we can see in this patient, the PR has no expression and the Ki67 is 10%. According to the AJCC guideline, this patient should classify as nominal A, but in Cisco and Xingrui guideline, the patient should classify into nominal B subtype. So the blueprint help us to better define the ER status with the ER function gene set shown in the below. Here included 80 genes assay for functional pathway. They included nominal subtype signature, about 58 genes included. So the MINDEC trial was the first trial for genomic assay in breast cancer to provide prospective randomized evidence of clinical utility in this important clinical questions. They identified the significant proportion of patients who could safely forgo the chemotherapy. For this patient, we can see the ER positive and grade 2, and then tumor size larger than 2 centimeters. So this patient is clinical high risk and also genomic high risk. So in this arm, this patient, in MINDEC trial, most of this patient went to chemotherapy alone. So the question is still be, seeing the memory print is high risk and blueprint is also high risk. Does this patient need adjuvant therapy? So after consult with the patient, consult with the experts in United States, we make a multidiscipline team to discuss, and they give us some advice. Professor Charles Bouch, who is the president of International Sentinel Society, he said, I agree that this patient should benefit from AI, but not adjuvant chemotherapy. He also gave us a reference to better make a decision in this early stage breast cancer patient. So Professor William Gradisher, who is the chair of breast cancer in NCCN guideline, he said, don't order tests from which you would not like the results. And he said would have to look at the patient, but his indication would be try to avoid the chemotherapy. The MINDEC trial would suggest she was still a risk of recurrence, but may be offset by chemotherapy. But the added benefit is likely to very minimal. If he select chemotherapy, he would likely to select 4-cycle TC, but not HCT. Past chair of American Society of Breast Surgeons, Professor Suzanne Klimberg states that the patient benefit of chemotherapy may be less than the risk of taking it, and agree with the endocrine therapy and dependent on bone densitometry and addition of isotonic. Dr. William would also support the idea of using the endocrine therapy, and he said the EBCTG overwhells show minimal to benefit of adding to cytotoxic in this age. Dr. Magan later also expressed that, said that nominal B subtype this patient with high-risk membrane, and we would consider adjuvant therapy. Okay, we received so many ideas from the United States experts. So I still want to ask, what's your opinion about this patient? Whether this patient is needed the chemotherapy? Actually, they have a controversial idea. So I want to know that whether the endocrine therapy alone is better for this patient. So thank you so much.
Okay, thank you, Dr. Lee. So we are going to move to the discussion about those two cases. So I'm going to introduce Dr. Zhu Li from Shanghai Jiaotong University Medical School and Raising Hospital, Dr. Zhu Li. And I'm going to very welcome our three experts, two from Shanghai, and also I want to welcome Dr. Trupny to join us for the discussion. So Dr. Zhu Li, she is going to chair the discussion. Welcome, Dr. Zhu.
Thank you, Professor Zhang. Can you hear me?
Yeah.
Okay. It's my pleasure to be the coordinator of this discussion part. And in this part, we have two cases. One is early breast cancer, and one is metastatic breast cancer. So let's begin with the early breast cancer from Guangdong People's Hospital first. Okay, I noticed that we still have two discussants.
So Dr. Zhu, you have to introduce our doctors first.
Okay. Our discussant, doctors, Professor Han Jing from Shanghai Dongfang Hospital, and she is a surgeon. And Professor Wang Chen is also from Shanghai, and he is also a surgeon. And we have a medical oncologist from Italy, Professor Dario Trapani. And I noticed that we still have two discussants from last session, Professor Song Chuangui from Fuzhou and Professor Li Xingrui from Wuhan. We will ask these five doctors to discuss in this part, okay? And Professor Song Chuangui, Professor, can you answer the question for the early case? And Dr. Li Zhuohui mentioned that this is a controversial for this patient, chemo or not chemo. And what's your opinion, Dr. Song?
Okay. For the early breast cancer presented by Dr. Li, I think that for early breast cancer have age 69 and the high genomic risk for relapse I think for these patients, I will suggest the patients to do the chemotherapy, such as the TC for 4 cycle. Yeah, this is my opinion.
Okay, and how about Dr. Li Xingrui?
Yeah, I agree with the Professor Song. Yeah, for the luminal B type breast cancer, especially this case, I will suggest the chemotherapy first. And in the same time, maybe we can do some 21 gene test or memoprint test, and we maybe use some endocrine therapy, such as OFS, or such as some can inhibit the estrogen receptor. Yeah.
Okay, and can we hear the suggestion from Professor Dario Trapani? And what's your opinion about this early breast cancer patient? Will you give chemo to this patient?
Yeah, thank you so much. So, well, this is really controversial, of course. It's the everyday controversies for these kind of patients. But my first question to the speaker is why they decided for mammoprint and not for the oncotype DX? Of course, because the TAILORx and MINDUCT were designed in a different way, and perhaps the predictive role of chemotherapy is better captured by the TAILORx. MINDUCT is more for the prognostic part. And of course, for luminal B-like tumors, because of the progesterone receptor low expression, Ki67 actually, I think, should be revised by a centralization of the pathology because it's low and I don't expect it to be low. All these elements really would prevent me first to ask for a revision of the pathology because I'm not 100% it's like correct. Perhaps I would understand what's the oncotype DX score because it can guide the prescription of chemotherapy, but I definitely agree to propend more for endocrine therapy alone because the magnitude of benefit from chemotherapy is like 1-2% at 5 years of overall survival on the overall population. And the TC is a little bit less than the anthracycline taxane. TC is likely a standard. So I'm not sure what we are giving to this patient. She's 69. I don't know about comorbidities, but I think the magnitude is low and should be discussed with the patient.
Okay, thank you for your opinion. And Dr. Li, can you answer the question why you do mammoprint not instead of oncotype DX?
Yes, because in China, 21 gene oncotype is still not approved in China. And the mammoprint is approved in China so we just proceed the assay with mammoprint.
Okay.
Thank you.
And so actually every doctors have the agreement and they will give this patient chemotherapy and most of them will give TC regimen. And do you have any questions about their suggestion, Dr. Li?
I think we should talk with the patient and her family because in this pandemic, most patients may are scared about coming back for chemotherapy. And the prediction, the prospect of this patient is very important since she is 69 years old. So maybe endocrine therapy alone has a very good prognosis that the 5-year survival is more than 90%. So I think you should talk more with the patient and her family.
Yes, sure. We will consider her comorbidity. Yes. If there is no further question about this case, we will move to the next case, the metastatic breast cancer patient from Tianjin Cancer Hospital, right? And actually, this case has no question for this case because if we have any comment for this case, because the treatment is quite good till now. So far, so good, right? So Dr. Han Jing and Dr. Wang Chen, if you have some comment for the second case.
Hello, Professor Zhu Li.
I'm very glad to give my comment with this case. So I also think it's a very good case for the treatment. It's for the metastasis, liver metastasis, stage 4 breast cancer, and the treatment is quite good. But at the end, we can see the mass is getting large again. And in this case, I would suggest the patient can accept the CD4/6 inhibitor combined with fulvestrant to treat the patient. This is my suggestion. Thank you.
Okay, Dr. Han will recommend fulvestrant instead of aromatase inhibitor. And what's your opinion? And Dr. Wang or under Professor Zhang, who present the case of second case？ 那个张景，刚才第2位那个讲病例的医生贵姓啊？我刚才没记住。
Professor Liu.
Hello.
Liu.
Liu. Okay, Dr. Liu. How about your opinion? Because Dr. Han will recommend this patient for fulvestrant with palbociclib. Do you have any? Yeah.
Yeah, I am agree with Professor Han because we can see the patient has achieved the good effects from the has benefits from the palbociclib. So I think maybe we can continue the treatment of it.
Okay, can I ask Dr. Dario Trapani, will you choose actually palbociclib may be the very a lot of solid data, but the combination of endocrine therapy, in this case, will you choose aromatase inhibitor and or fulvestrant?
Well, this patient is de novo metastatic because when she was diagnosed, she was locally advanced and she had a metastatic disease. So according to the clinical data, we should choose for aromatase inhibitor. She's premenopausal, so of course she's receiving ovarian suppression. My only question for this case actually is really why you decided for a primary chemotherapy, unless though the patient was not really in a visceral crisis. So we can choose for primary endocrine therapy for metastatic disease when there is no need for chemotherapy. She received a combination of anthracycline and taxane that was quite hard. And she had no really good benefit because she progressed after 3 cycles, after, like the first cycles.
Okay, Dr. Liu, can you explain that? Why you give chemotherapy, TE regimen for this patient?
Well, for this patient, maybe she's the stage 4 patients, but because for although the patient is a stage 4, but I think the first choice for the patient, because the patient also has a liver metastasis. So in our opinion, we have to choose the chemotherapy for the first regimen.
Actually, I will agree with Dr. Trapani, and because the liver metastatic lesion is only one, and there's no visceral crisis. So in my clinical practice, I think I will give endocrine therapy with CDK4/6 inhibitor for this patient. Yes.
Okay.
Okay. 最后那个汪教授有没有什么要和我们分享的观点？我觉得用中文讲也可以，我可以如果有什么我可以翻译给意大利医生听。
好，我现在谢谢朱教授，因为我的口语不太好。就是我觉得第一个病例里面关于这种临床高危和基因低危这个因素的分析，其实还是有很多值得探讨的地位。的确是在临床一些虽然是容纳避险，但是它还是一个从分型上面还是一个中危的病人。那么虽然基因检测是一个高危的一个人群，那么对于做不做化疗，我个人觉得采取非常谨慎的一个态度。特别这个病人是69岁， 从基因的角度可能是高危素和需要做，又是个lumina B 型的病人，但是从目前的临床行政医学证据上面，它对于深层的改善只是改善了0.8%左右，所以说对临床上对病人还是个体化的一个选择。那么对第二个病例，我觉得 CDK4/6抑制剂的确在这种晚期的乳腺它取得非常好的一个疗效。那么同样，我们还是对于 CDK 以后的出现第二次耐药的以后进展以后，我们采取什么样的策略？包括3个 CDK 抑制剂之间的转化，包括我们相关的一些生物标记物的一些测定，可能会对我们整个后续的治疗有很好的一个指导意义。好的。
好，thank you for your comment, and I have to discuss close this session and move my microphone to our chairman, Professor Zhang.
Thank you, Professor Zhu. And then I just want to say thank you very much for all doctors for all your contribution for those cases. Definitely we have time limited. So for those cases, especially for the advanced breast cancer, I want to hear about the opinion from Professor Xu, and then also I do hope that Professor Xu gave the summary of our online meeting. Professor Xu.
Okay, thank you, Dr. Zhang. Now we are going to close our online meeting. Thanks for all speakers, moderators, discussing guests, and audience. It's really a wonderful 2 hours for me and hopefully for you as well. In the first part, Dr. Chao introduced the situation of the epidemic of COVID-19 and the caution for medical workers. Professor Curigliano gave us a very impressive speech. From his report, we know how Italian doctors care for breast cancer patients and the current situation. Dr. Liao and Dr. Yao shared their experience in breast cancer diagnosis and treatment under the epidemic of COVID-19. In the second part, Dr. Li and Dr. Liu shared 2 very interesting breast cancer cases. Once again, thanks a lot for all of you. Please be safety at this very moment. Looking forward to see you soon. Thank you.
Thank you.
Thank you, Dr. Xu.
Bye-bye.
Thank you. Bye.
Thank you.
Bye. Bye-bye. Thank you.
Thank you.
Bye.